Good day, everyone. I'm Stanley. Today, we are going to look into one of the key and essential components of ACLS, Advanced Cardiac Life Support. I am referring to, as shown in this title, the ACLS cardiac arrest algorithm. As you might already have learned from previous presentations of this learning module, ACLS refers to a set of clinical guidelines for the urgent and emergent treatment of life-threatening cardiovascular conditions that will cause or have caused cardiac arrest, using advanced medical procedures, medications, and techniques. In this presentation, we're going to spend around 10 minutes having an overview of the cardiac arrest algorithm. Hopefully, after this presentation, you will become familiar with the cardiac arrest algorithm, and more importantly, through us highlighting to you some of the important aspects of this algorithm, you'll also be able to confer the knowledge into the best possible outcome for individuals who are experiencing a life-threatening event. As you can imagine, in situations where a cardiac arrest algorithm is required, the situation is going to be very intense. It will be rather helpful to equip yourself with these knowledge so that you can keep calm and execute what you've learned in helping the people in need. There will be a mini quiz at the end of this presentation, but I'm sure you will be able to score very well. And hopefully through this quiz, we'll be able to consolidate the knowledge a bit more. Okay, to get this rolling, let's first have a look at this short clip to get a taste of cardiac arrest algorithm.
Ms. Fernandez, Mrs. Fernandez, can you hear me? Mrs. Fernandez. She's unresponsive.
I don't feel a pulse.
Okay, let's call a code. The patient's gone into VFib. Start chest compressions.
Starting compressions.
Mandel, you'll be on defibrillator. Shelley, you'll be recording.
Recording.
Sam, you'll manage the airway. Dana, have you been able to establish an IV access yet?
I've tried several times, but it's failed.
Okay, let's move on to IO access, please.
Moving to IO access.
24, 25, 26, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Charging at 200 joules. Shock ready, clear the patient. Shocking on 3. 1, 2, 3. Shocking. Shock delivered.
I have IO access now.
Great. We'll continue CPR for 2 minutes and evaluate the need for additional defibrillation. Shelley, I'll rely on you to monitor the quality of the chest compressions. Dana, you'll need to draw the drugs up before each rhythm check, so if the arrest persists, we can move quickly to drug therapy. Let's begin with 1 milligram of epinephrine.
Drawing 1 milligram epinephrine.
Well, as you can see, it was very intense, and in the room there was a very serious atmosphere, but everybody was very clear what they're doing, and the instructions were very clear, the process was very swift. This is, of course, very exemplary. So, to tickle your brain, to tease your brain a bit, I'd like to start off with a question. What is the first thing that you do when you detect a cardiac arrest in hospital? Okay, I'm going to give you 10 seconds to read the options here. It is important to start the resuscitation well, so I think the first thing we need to do is to know what we do in the first step. Remember this question, and hopefully after this presentation, we'll all know the answer to this question for sure. Okay, you don't have to answer me that right now. Just remember this, and we'll come back to it later on. So without further ado, let's introduce ourselves to this algorithm of interest, the cardiac arrest circle algorithm. The top part denotes how it should be started, hopefully answering the question we had just now. Start CPR, give oxygen, attach monitor and defibrillator. And the subsequent circular flow beneath denotes the steps that follow the cycle. The cycle completes in 2 minutes, as you can see from the mark here. And in this presentation, we're going to touch on several areas. First, we would learn how to recognize certain rhythms. You'll find why it is important later on. We'll learn how to ensure CPR quality. We'll touch on drug therapy during CPR. We're going to brush on advanced airway and talk about shock energy, and of course, highlighting the treatment of reversible causes in due time. Cool. So this is, again, the circular algorithm of cardiac arrest. In the next 10 minutes, we're going to touch very succinctly on those topics. Assume you start CPR. Let's focus on the top part of this algorithm. You start CPR followed by giving oxygen and attaching monitor and defibrillator. As I've said, starting CPR right is very important. So this part, please do not forget this part, how to start CPR well. And while the CPR process is ongoing, you will be faced with the first challenge very soon, reading or analyzing the first rhythm you might get. The essence is to differentiate whether the rhythm you see is a shockable or a non-shockable rhythm. As the name suggests, it leads to a very different subsequent management steps, as you can also see from this flow diagram. Now let's show the prime examples of shockable rhythms. We're now going to first look at the first one on top, right here. Take a look. Notice the irregular and unformed QRS complexes. You don't see a very clear P wave. It's very unformed QRS complexes, as I've said. As you can see from this title, this clip topic, this title of the clip, this abnormal heart rhythm occurs when the ventricles of the heart simply quivers and shudders. This is the typical ventricular fibrillation, or VF, or VFib. Basically, we can have a look again. Basically, in VF, the ventricular muscle twitches randomly rather than in a, very constructive and coordinated manner. And because of this, the blood doesn't really get pumped through the body very effectively, and thereby having a cardiac arrest. Recognize this pattern as a timely shock can reverse it. So this is a ventricular fibrillation. Also notice how the heart rate changes. Okay. In contrast, let's take a look at the one below. Notice the fast heart rate in this one. Also the regular wide QRS complexes. Can I have a look again? What's shown here is a ventricular tachycardia, or VT, or VTach, as somebody calls it. Monomorphic, to be exact. So as you can see, it's very wide complex, more than 120 milliseconds. It's defined as more than 3 consecutive ventricular beats with rates over 120 with wide QRS complexes. This is VT. Remember these two rhythms as they are shockable rhythms, VF and VT. How about non-shockable rhythms? Okay, this is an example of asystole. Remember, asystole is non-shockable. And while we are very obsessed with shockable and non-shockable abnormal rhythms, we do have to remember what a sinus rhythm looks like. Have a quick look. Yep. While we talk about shocks, more about the shock itself. Biphasic defibrillators, in contrast to monophasic ones, use a variety of waveforms and have been shown to be more effective for terminating a fatal arrhythmia. That's why it's recommended in ACLS when using biphasic defibrillators, providers should use the manufacturer's recommended energy dose. So, for example, initial dose of 120 to 200 joules. If it's a known, as stated here in the slide, use the maximum available one. This is just to remind you. For the next slide, good CPR, of course, is important, gives good outcomes. So next we shall talk about ensuring the things to look out for in ensuring good CPR quality. In the next presentation, after this presentation, we will touch more deeply on this, but the CPR quality is too important to leave out in this one. So I'm going to pick some important ones to remind us. So remember to, first, as you can see, press deep and hard enough, at least 5 centimeters when doing chest compressions. Push fast enough, 100 to 120 beats per minute, or presses per minute. Remember to allow a complete chest recoil. Also, please do minimize interruptions in compressions. Avoid fatigue by rotating compressor every 2 minutes. Regarding drug therapy, for all cardiac arrests, use epinephrine or amiodarone. Epinephrine, 1 milligrams every 3 to 5 minutes. Amiodarone, first dose is 300 milligrams in bolus, second dose is 150 milligrams. For refractory shock rhythms such as VT and VF, defined as after 3 shocks, use lidocaine. First dose being, as stated, 1 to 1.5 milligrams per kilograms. Second dose, as stated, 0.5 to 0.75 milligrams per kilogram. This slide is important and has quite a number of intricate numbers on it, so I'm going to leave it for a while to let it sink in for you. Okay. This next slide brushes on establishing advanced airways. As mentioned, this will be elaborated much further in our small group practicum later on. For now, I would stress this. Do remember to avoid hyperventilation. For this next slide, we're going to touch on the reversible, treatable causes. While the CPR is ongoing, we have to work in parallel to ensure that reversible causes are attended to and treated for. The 5H5T mnemonic is a good way for us to remember these common reversible causes. And these are the 5H and 5Ts. Okay, we're arriving at the final parts of the presentation. For return of spontaneous circulation, at some point your patient might have return of spontaneous circulation. It is crucial to acknowledge when this occurs. Features are as follow. Right, so that's the end of this succinct touch on the cardiac arrest algorithm. We've touched on several main points. More will be elaborated in the small group practicum, as mentioned. We've touched on recognizing the rhythms, the VT-VR, asystole, sinus rhythm, not to forget which are shockable. The first two, VT-VF, are shockable. Non-shockable ones are asystole and sinus rhythms, and others. We've learned how and when to shock, the energy, the mode being biphasic, how to ensure CPR quality, and we've touched on appropriate drug therapy, use of epinephrine, amiodarone, and lidocaine. And of course, not to forget the treatment of reversible causes and recognizing features of return of spontaneous circulation. Thank you for sticking with us to this point, and I'll see you at the end of the quiz, and which I'm sure you're going to do very well. Thank you very much.